Welcome back, everybody. Now I'm delighted to introduce another longtime colleague and our third keynote speaker, Professor Jorma Rantanen. Dr. Rantanen's contributions to international occupational health and safety over many decades are too numerous to count. Suffice it to say that until 2003, he served for 30 years as Professor and Director General of the Finnish Institute of Occupational Health, one of the premier national occupational safety and health institutes in the world, and it has served as a model for innovative approaches to the protection of workers. He's not only an accomplished researcher with over 500 publications, but also a widely sought out expert for international agencies, including the World Health Organization, the International Labour Organization, United Nations Environmental Programme, the EU, and the International Commission on Occupational Health. Professor Rantanen, it's a privilege and an honor to introduce you, and it's so good to have you with us.
Okay, I was invited to discuss educational strategies for occupational health professionals in Europe. I'm going to discuss briefly also occupational safety people's training strategies, but less than occupational health people because it is my field of specialty. In fact, the European Union is regulating working life pretty effectively, as US is doing also. But now it is a new trend. They also start to regulate the competencies of people, and we have a new, relatively new directive, not that new, 2005, it was passed, which is stipulating the competence requirements for skilled workers in any kind of professional fields. And particularly it's targeted to professional people, including safety and health people, which means that you have to have evidence on your competence in any occupation or any profession you are carrying out in practice. And that is pretty demanding directive. It has several arguments behind why it has been stipulated. First, it facilitates the mobility of temporary skilled professionals between EU 27 member countries. It also helps the settling down of the professionals in some other EU country but their home country permanently. It also takes into consideration the language skills. We have more than 20 languages in the European Union area, and in order to work as a professional, you have to have sufficient language skills to work with the language of your new country. And also it facilitates recognition of professional and academic titles and competencies across the European Union. It has 3 different types of recognitions of qualifications: automatic recognition for professionals who have some kind of internationally recognized competence. Secondly, it has a general recognition of the regulated professionals like medical doctors. And then it has also the third group of, let's say, special cases which are recognized, like airline pilots and so on. This is also valid for occupational safety and health people, as I mentioned. We have an EU strategic framework on health and safety at work, which is covering the period 21-27, and it has certain important items included. First, it is aiming to mobilize European institutions, member states, social partners, and other relevant stakeholders around common priorities of workers' health and safety protection. It applies to all relevant actors and partners. Secondly, Commission, according to this strategy, will work with member states and social partners, employers and workers, to address change in the new world of work, which is universal objective in every country. It also works for improving prevention of workplace accidents and illnesses in line with the Vision Zero. And this Vision Zero is very important in Europe. It is, in fact, the totally shooting down the earlier theories of safety people, of residual risks and unavoidable risks. It simply says that, yes, occupational safety and health problems are all preventable and they should be prevented. It's, again, pretty demanding. And the strategy also addresses to the potential future health risks and crises like we now experience the pandemic. Commission also challenges the member states to update and draw up their OSS strategies according to this European framework strategy. And in 2023, we will have again heads of the state summit, which will take in the agenda the implementation of this strategy. This is a kind of political and partly also regulatory background of occupational safety and health in Europe, also affecting the training and education of experts and their competencies and so on. The EU strategy framework has those three main aims and items which I already practically mentioned: anticipating and managing the new world of work, improving prevention of work-related diseases and accidents, and increasing preparedness for future health threats. This is going to be, until 2027, the key content of European OSS strategies. One of those important civil society and professional supporters is the European Network of Education and Training in Occupational Safety and Health, ENETOS abbreviation. It provides a platform for systematic exchange of knowledge and experiences on education and training related to safety and health and well-being at work. ENETOS has 39 European member countries, 4 partners in Asia, 3 in Africa, and USA is also ENETOS partner. ENETOS has relatively simple objectives: to integrate safety, health, and well-being into education system at all levels, and to promote transdisciplinary and transnational cooperation between following policy areas: childcare, school, primary and secondary education, initial vocational education and training, higher education, and continuing vocational education and training, which is the SWET abbreviation. In fact, this is something unique because European network takes occupational safety and health issues already as an educational item for child childhood time and child education. Also, child care, safety and health in child care is considered. This is originally Swedes did this for decades ago, but now it seems to spread in the whole Europe with this network. By the way, European Union is not limiting its activities for training and education and occupational safety and health to member countries only, 27 member countries. It goes up to 50 countries in the whole one European system. And they are surprisingly interested to participate in our EU programs. In, for instance, Kazakhstan, in Azerbaijan, and so on, those former socialist countries. These Enetos pillars are very important because they also show some picture of the whole European occupational safety and health policies and principles. First, Europe is very strong in social rights, and therefore it is one of the important also in occupational safety and health that the workers have their social rights. Secondly, which is a little bit surprising probably, that European Union has encouraged the civil society bodies, professional bodies, to commit to the achievement of sustainable development goals in all sectors of the society, and also sustainable development goal for quality education according to the UNESCO objectives. Secondly, I'm going to speak more about European education area, which is very important here. It is politically strongly supported, and Enetos wants to be partner in European education area, which is called EEHA, higher education area. And then it takes also those vulnerable groups into consideration, women and children, adolescents. Digital education action plan is important element also in Enetos pillar, and then this occupational safety and health strategy of EU. Enetos tries to contribute and participate to all these. Enetos has a big network covering really 39 countries. And as you can see, even Russia is part of Enetos network, which is important because they have a tendency to isolate, and then they are at risk to lag behind, and it always means that kind of imbalance always means also political problems later on. Here is the map of Enetos participant countries. Then I will move to other, which is practically the most important issue in my presentation, is the Bologna process and European higher education area, EHEA. I guess most of the participants know Bologna process. It is so well established and so well known. But Bologna process was started before 2000 already. In fact, 1998. British, French, Italian and German ministers of education agreed on starting a pan-European program which is modernizing, effectivizing and making better quality of higher education in all areas, all disciplines, but including also technology and medicine. It is very consistent European policy for EHEA. And ministers of education convene every second year to follow up the implementation of this education area. It contains important substantive points which aim at harmonization of curricula and degree exams throughout Europe, ensure high quality of higher education, exchange international experiences, and one of the most important is student exchange between countries, which is very active right now. I am going a little bit later to that. I took an example of ministerial meeting 2015, which identified 4 key priorities for the future Bologna process within the education area. Enhancing the quality and relevance of learning and teaching, fostering the employability of graduates throughout their working lives, making our systems more inclusive, and implementing agreed structural reforms in higher education system, which means also the structures of competence exams. This process seems to be very strongly sustaining in spite of all the other problems we have right now in Europe, like several political problems, even British Brexit. They are involved still in this education area. We have many other political problems partly in Eastern Europe and some in Southern Europe. But in spite of all these difficulties, education area makes progress. And it is also a follow-up and evaluated continuously by the higher political level and also by expert bodies. It is, I think somebody could say, it is very, very pregnant initiative of European Union. Bologna objectives are many. I have listed them here. Foundation of European higher education area, establish a simple comparable system for studies, adopt 3 cycles of degrees, bachelor, not master, master and doctor, establish a single comparable system for grades, establish a common measurement system for studies, facilitate mobility of students by eliminating administrative and other obstacles, and now most important, Erasmus. Erasmus is a program for funding the exchange of students from country to country so that young people can go to UK, France, Germany, from northern countries to study there a year or a couple of years and get that experience, and also get a lot of contacts and understanding of the what we call pan-European culture. It also aims at enhancing European quality control system for education, higher education, develop coverage and attractiveness of the European higher education system, apply lifelong learning principles, increase students' participation in facilitation of studies and deciding on studies, and it in general tries to modernize European higher education studies, including also for research technology studies and medical studies. We have also in Europe pan-European credit transfer system, and that makes easier to compare the study programs and also grades of students' achievements. In fact, that Erasmus, which facilitates the exchange of students and also partly in educators, it invests now 26 billion euros for 21-27 period. And Europe has developed a common quality assurance system and accreditation for academic studies. Here are the countries which are part, again, 48 countries far beyond the borders of European Union, including Eastern and Southeastern European states, which are not members of the Union yet. Here is the follow-up group strategic plan. I'm not going into the details, but just it has working groups on implementation, on fundamental values, on coordination of global policy dialogue, on social dimension in education, learning and teaching methods and research, and San Marino roadmap, which is a practical-oriented roadmap for higher education. They follow very carefully, and they also evaluate periodically the implementation in different countries, which is very educational for everyone, and also some way challenge for countries to implement the Bologna strategy. Ministers, as I mentioned, they convene every second year. This is the latest ministerial meeting in 2020 in Rome. I just will read you as an example what they used to agree between education area ministers of education or educational area. First, they want to emphasize, and with good reason, fundamental values of higher education and democracy and the rule of law. I think this is some kind of response for some negative phenomena which has been seen in the world in over competition of universities and researchers and educators, and not always following fair principles. Secondly, they want to stimulate and support the major changes in academic system, making them more modern, more living with the everyday society, improving the knowledge, skills and competencies of students and the whole society. This is very important substantive object. They also want to support, as I mentioned, Sustainable Development Goals of United Nations by using higher education as an instrument. Quality of education is important, and a robust culture of academic and scientific integrity, which is also preventing fraud and misuse of institutions. This was last ministerial meeting's key content, and 2023 they meet again and certainly will pick totally new items. For instance, I could imagine that pandemic will be some way in the agenda. Okay, and these are also supported by medical specialists and medical communities, associations. The most prominent of them is UEMS, UEMS. It is the Union of European Medical Specialists, and it has a special occupational medicine section, which is dealing with occupational health issues and promoting occupational health in general terms. It has three key areas of interest: continuing medical education and professional development in occupational health, postgraduate medical training, and quality assurance of education. UEM's occupational medicine perspectives on renewal of European curricula for occupational health is highly topical issue. In fact, we have been outdated. We even speak about occupational medicine, but we, particularly in the Nordic countries, we have started to speak about occupational health. A part of occupational health is occupational medicine, but occupational health contains also many other aspects, but medical diagnosis and clinical medicine only. It has, for instance, in Finland, we have stipulated even in our law that we have 5 main elements in Finnish occupational health content. One is prevention, second, promotion, third is care, curative activities, fourth is rehabilitation, and fifth is first aid and emergencies. This is the content what we call comprehensive occupational health. It is not only diagnosis of occupational diseases, it is also in the main focus nowadays is in prevention and making appropriate changes at the workplace, not only focusing to individual worker as a patient. This is very strong Nordic trend nowadays. Okay, we need to renew European occupational medicine radically. And that is the process which is right now going on. And really, it is aiming at making occupational health not only clinical occupational medicine, but also more multidisciplinary and more comprehensive by content. Europeans have also started pan-European exam for occupational health specialists. In fact, so far 2 specialist exams have been organized, and UEMS is the main organizer of that exam. In January 2020 and in August 2020, they organized already the exams, and it was a good lesson for all of us how to make more harmonized European competencies and degrees in occupational health field. We have also those objectives for exams and for competencies of occupational health specialists. First, they have to be able to work in practice. They have to command certain part of clinical practice to identify the key occupational diseases, for instance. They have to be able to check the fitness to work, rehabilitation and disability assessment, which is possible to do in occupational health units. They have to be strong in hazard identification and recognition, evaluation and risk assessment. They have to also look at the disaster preparedness, emergency management. They have to be able to conduct quality service delivery, provide high quality services, occupational health services. They have to be able to lead the occupational health units. They have to have some at least elementary knowledge on epidemiology and preventive occupational health activities. They have to be basically trained in research methods also, for instance, surveys and let's say some functional measurement of workers' activities, and they have to be effective in teaching and educational supervision. Occupational health physicians need to teach a lot of workers, for instance, and very much also employers, and they have to have certain skills to do that. So this is the new competence setting and exam practice, which is now getting more and more common in European Union area and those other education area countries. EASOM is another professional body which is closely working with the Commission and with the OEMs. It has a mission to promote the highest standards of education and training in occupational medicine in Europe. They use still medicine word, the word, and they do that mainly in exchange of knowledge, skills, and experiences of teaching and training. The most important activity by EASOM is summer schools, European summer schools, which have been very popular. The best educators in whole Europe are collected to educate in the summer schools, and students from all those 39 countries can apply for courses, and they are all recognized as formal parts of training curricula for specialties. It is very useful, and it completes very well what the OEMs is doing for competence requirements and exams. Now EASOM will produce the abilities to go to the exams and accumulate that competence. Okay, next point is I thought to give some example of individual country, and of course you can imagine I take Finland as a case. But I have not only the reason that it is my home country, but Finland probably has the widest coverage of occupational health services in Europe, and it also has probably the most comprehensive content. And the reason is that we very early, already in early 70s, we stipulated a special occupational health service law. As in most of the other European countries, occupational health services is stipulated by a couple of paragraphs in occupational safety law. And even European Directive on Occupational Safety and Health is practically only safety regulation, not occupational health regulation. And we have benefited very much of this, and particularly now, when aging workers are coming to picture more and more, chronically ill, vulnerable groups are getting more attention. They are issues which cannot so easily be handled by safety engineers. They need medical competence and occupational health competence. And therefore, we have been fortunate that we were early preparing already for this kind of more changes. And now you can imagine what is the situation when COVID is spreading, which is purely medical issue and needs a lot of medical competence. We have a strong occupational health service infrastructure, which has helped us a lot in management of COVID pandemic. Not perfectly, but anyway, relatively well. The regulatory basis of the Finnish Occupational Health Service is based on law that I mentioned. It stipulates that the employer has to provide services, occupational health services, for all employees. Even the case he or she would have a housemaid, occupational health service has to be provided for. And self-employed are entitled to get service if they want, but we were not able to stipulate them the obligation to take because it had been against constitution. Anyway, Finnish occupational health system is very comprehensive, covering probably the highest percentage of working people in the world. We have also substantive content stipulated by Finnish government ordinance. Its name is Ordinance on Good Occupational Health Practice. It stipulates the content and activities of occupational health services, and they are just representing that comprehensive occupational health, where occupational medicine is a small piece, while those prevention, promotion, protection, rehabilitation, and even care are the most important ones. We have also some other laws which are related to occupational health service system, which in fact has been very, very good to support development of our system. First, we have so-called law on work income insurance. Every employer and every worker is stipulated to take insurance for which is called work income insurance, but it is only aiming to finance occupational health services so that the premium by employer will cover the costs of compulsory preventive activities which employees is liable to provide. And then employers and workers together finance with their insurance fees the curative activities which are something else but work-related. So work-related health problems are financed by employer, but if you take, for instance, the flu service for flu or some other non-occupational health problem, then also workers financing is used. They still have benefit from that. We have a totally covering primary healthcare system in Finland, but usually the queues are there so long that workers who need to get back quickly to work, they prefer to use occupational health services curative activities for their service provision. We have numerous lower level regulations and guidelines for occupational health services, how they are implemented, how they are realized. I'm not going to give those details, but one important rule is that occupational health expert cannot be any health personnel who happen to be available. They have to have a specially stipulated competence, their competence requirements, and for instance, a full-time occupational health physician must be a specialist in occupational health. So, for instance, general practitioner cannot provide occupational health services, and with full good reason, because usually they are not competent. They don't know working conditions. They don't know work hazards and so on. What they used to do, if they do just general curative services and not prevention. So we have wanted to ensure that what is provided in occupational health service, it is competent service made by competent experts. As I mentioned, the service infrastructure in Finland is pretty developed. All working people, employees and self-employed, are entitled to access to occupational health services. Currently, out of our a bit more than 2 million workforce workers, 1.9 million workers are covered by occupational health services. It's 91% of employees, and if we count also the self-employed and entrepreneurs, the coverage is 82% of all working people. Our services are occupational health services are produced by over 450 occupational health units. 70% of them are private medical centers, 30% are public or so-called joint services by associations owned by SME companies. This is probably the world's largest covering occupational health system so far. Here we see that we have since 2000 our costs of occupational health services have grown, but they are now leveling off as workforce is no more growing. And we used to invest something like 500 euros per worker per year for occupational health services. We consider it as a relatively reasonable sum of maintaining the workability and health of people who take part in the work life and in fact produce the whole GDP of the country. No, I don't get again no. This is the graph on our comprehensive occupational health service system. In fact, this is directly drawn from the government ordinance on good occupational health practice. Let me explain a little bit this system. First, our targets are not only worker. We have also the work environment and work organization as a target. Everything which is done outside the cycle is oriented and focusing to work environment and hazards at work. And everything which is inside the cycle are targeted to worker and his health, his work ability, his risks, and so on. And we shuttle all the time between the work environment data and work environment observations and workers' health observations. And this is the combination which works relatively nicely in our occupational health service system. And we have specially trained our specialists to do this kind of job. They start from orientation, getting to know the workplace. They do the surveillance of working environment, identifying the hazards and job loads and so on. They make a systematic risk assessment. They inform the employers and workers on the risks they have observed. They help in preventive actions. They may measure the hygiene and safety measurements. They also do accident prevention, control technology, emergency readiness, record keeping, and evaluation of their own activity. This is the outside cycle. And inside, they survey workers' health, assess individuals' health risks. They use health education and health information. They also advise on general hygiene, which has been now very important in COVID times. They provide first aid. They provide diagnosis of occupational diseases. They promote and maintain workability. We have special research programs even for that and special methodologies. They also provide general health services, early rehabilitation and health promotion. So this is the Finnish occupational health package in a peanut. And it works relatively well. The bigger is the occupational health service unit, the better it works. Of course, smaller units with one physician and nurse only, they have difficulties to run that comprehensive type of service. We have a relatively well-developed occupational health service resources. We have something like 2,300 occupational health physicians. We have a similar number of occupational health nurses, well-trained, specialized nurses. We have physiotherapists. I think today they are more than 1,000. We have psychologists, something 300 to 400. We have some assistant staff. The total Finnish occupational health service staff is something like 7,000 people, which is, of course, not sufficient, but relatively reasonable number of trained people. We had earlier so many occupational health service units. Now they have merged very much and very quickly together, so that we have now only something like 450 units in Finland active. They have swallowed those big units, all those small entrepreneurs in the field. We have special national occupational health service strategy, which is also has a status of government resolution. In fact, it is a legal document. Now it extends to 2025. It contains, of course, all those what existing legislation is stipulating, but now special emphasis is given to customer-centered occupational health services, particularly for small and medium-sized enterprises, for different types of clients, special tuned services in program. And now, of course, we need to prepare for growing importance of digital services and also IT works. Health and workability for all working agents is extremely important. Therefore, that our workforce is aging, and particularly the psychosocial hazards and risks are growing rapidly, and we, honestly speaking, have not been sufficiently prepared for that. What is integrating everything is the concept of workability. Workability is derived from health, skill, competence, and motivation. And we have to take care of all these elements in the workability of the working people and support the participation in the working life and support also the interest to stay healthy and maintain that workability so that they can sustain their families and live long working careers, which is also the formal objective of Finnish occupational and working life strategies. We also want to develop our occupational health service processes, resources, and the reimbursement system, which I described on the basis of the work income insurance. And we are interested, as European whole educational area is interested in improving quality and effectiveness of our services. Research and development is important element, particularly in the modern work life. And then, of course, modern education of occupational health professional. Not only physicians, but also nurses, ergonomists, physiotherapists, industrial occupational hygienists, psychologists. And we have them, for them, relatively systematic training programs, but not that terribly systematic like for occupational health physicians and nurses, which for traditional reasons are very well established. Here are the competence criteria for occupational health service people. They need to have the licensing of National Supervisory Authority of medical authority. They can be branded as physician, nurse, public health nurse, psychologist, or psychotherapist. So enabling multidisciplinary occupational health team. And we may have some special criteria also, like a full-time occupational health physician really has to be specialist, as I mentioned. Part-time needs 15 credit points courses in occupational health services in order to be allowed to enter the occupational health services in the workplace. Public health nurse has a parallel type of competence criteria as if she or he is going to work as occupational health nurse. In fact, Institute of Occupational Health gives even special period of occupational health nursing education for public health nurses when they come from the University of Applied Research to the market. Here is the occupational health physicians training curriculum, which is 6 years long. First, basic qualification training, 2 years. I think this is very much like American any specialist course, but I think I have the impression that US has a shorter 4-year curriculum instead of 6 years of ours, which is I think the difference also between European and non-European countries. They serve in the municipal health center or hospital 1 year, then they serve half a year as an introductory period in occupational health services just to learn what kind of activity is it, and then they have to go to other disciplines of medicine for 6 to 9 months, which is approved by the university, so that they cannot go anywhere. They have to have an approved place for serving and learning practice there. Then we have 4 years specialization training, which is 2 years in occupational health units, rotation in other clinics, partly pulmonary clinic or surgical or orthopedic or rehabilitation are common where they go for 1 year. And then they have also special courses for curricula for workability and physical rehabilitation of 6 months, which is provided by university occupational health units like our Helsinki University Occupational Health Unit. And then they serve the last 6 months as a fine-tuning in the Finnish Institute of Occupational Health Medical Clinic. They have to do, when they are partly in companies, learning under the leadership of senior tutor, they have to use fill logbook, and logbook is going to be examined by the university professor every 6 months, and also always when you are rotating to other place. Then we have the exam, national written exam for specialist physician in occupational health. And that is provided by the 5 different faculties of our universities, which are training occupational health and approved by the national authority. I will not speak about virtual university. We have had 10 years the virtual university for occupational health, combining all the knowledge and efforts of 5 university faculties in occupational health to support our national training programs. Cochrane collaboration is also founded in Finland for occupational health field. Now it is in Amsterdam. I don't speak about that anymore. And also the challenges I have listed in my future challenges I have listed in my slides, but you can read them they are not new for you, I guess. And now my summary. I would like to summarize my presentation as follows. The European occupational health and occupational safety and health training strategies are coordinated by EU Commission with support of the Parliament. And I have spelling. And technical support is provided by special EU Occupational Safety and Health Institution, EU OSHA. You many know it well. The interest and influence of the EU goes far beyond the union limits to whole European continent, also to the non-member countries. The total target countries number is something like 40 to 50, depending on the activity. There is a strong trend for harmonization of competence requirements, training curricula, quality and competence testing of specializing occupational safety and health and occupational health experts. And this aims at free movement of experts and professionals from country to country within the EU area. When competence has been harmonized, you are able to work in any country you want to do. The global trend in competence, knowledge and skill-based strategies are dominating ahead of the former time-based. It means EPAs. The Commission and EU OSHA coordinate training of experts for occupational health specialists according to the Bologna process, which is applied also in this field of competence. And numerous voluntary, professional and civil society bodies participate in all stages of the strategy planning and implementation, for instance, UEMS and EASO. Okay, thank you very much. This is my presentation.
Thank you, Jorma, for sharing your insight on this topic. Clearly, the discussion on needed changes, modifications, and adaptations of how we train occupational safety and health professionals is in full swing on both sides of the Atlantic, and in this XPHOSH conference as well. Right now we have another short break, after which we'll move on to our first set of concurrent sessions, followed a bit later in the morning by our second plenary session, moderated on this occasion by Dr. Faiz Bojani, which includes presentations from an invited panel of experts who will talk about the occupational safety and health future of work, partnerships, perspectives, policy, and practice. You'll really enjoy this one, so see you back here in a bit.